Starting off with the anaphylactic shock. Anaphylactic shock is a potentially life-threatening condition which is characterized by type 1 hypersensitivity reaction. It presents as either a circulatory collapse, bronchospasm, stridor, or urticaria. The mechanism, the allergen that enters the body is recognized by the B cells. B cells convert into plasma cells, and these plasma cells give rise to immunoglobulin E. Immunoglobulin E attaches to the surface of the mast cells and the basophils, and upon re-exposure, there is a degranulation happens. This degranulation releases the mediators like histamine, prostaglandin, and leukotriene. Effects of the mediators. Because of the effect of the mediators, there is vasodilation leading to hypertension, shock, increased vasopermeability leading to edema, then bronchoconstriction causing wheezing and breathlessness. If it is not mediated by Ig, then that is called as anaphylactic reaction. Clinical features in the respiratory system, it will lead to bronchospasm, laryngospasm leading to stridor, wheezing. Then cardiovascular, there is hypotension, shock, circulatory collapse. In the CNS, it will lead to dizziness, syncope. In the skin and mucosa, there is a urticaria, that is hives, and apart from that, angioedema, that is swelling, especially on the face and lips. GI, it will lead to abdominal pain, diarrhea, and the investigations. So investigation is the serum mast cell tryptase levels and specific IgE testing by radioisotope assay, the skin prick test. Management. For acute emergency management, we first adrenaline 0.5 mg 1:1000 dilution intramuscularly in the mid outer thigh. Then the airway management, breathing and circulation, that is ABC, should be done. The patient should be in the left lateral position with the legs elevated, administer the IV fluids to manage the hypertension. Then bronchodilators are given, nebulized salbutamol. For bronchospasm, antihistaminics, that is intramuscular IV diphenhydramine or chlorpheniramine, and corticosteroids, that is heavy hypocortisone, to prevent the delayed reactions. Then post-recovery management. In the post-recovery management, identify and avoid the triggering allergen and provide an adrenaline auto-injector or EpiPen for future emergencies. Educate the patient on early recognition of symptoms and self-injection techniques. Then the next topic will be poisoning. So the first we'll talk about the sulfose poisoning. So sulfose poisoning is a brand name for aluminum phosphide, which is a common rodenticide, that is the rat poison that is taken especially in case of North India. It is frequent method used for suicide, and the mortality rate is up to 60%. 2 to 3 tablets can be lethal. Now upon ingestion, this sulfose, it gets converted into phosphine gas, and this phosphine gas is highly toxic in nature. It is going to inhibit the cytochrome C oxidase in the electron transport chain, and because of which severe energy deficit is seen and ATP crisis. Then clinical features in the respiratory, it will lead to chest tightness, wheezing, breathlessness, leading to ARDS. Then gastrointestinal, it will be abdominal pain, diarrhea, vomiting. Then in the cardiovascular, it will lead to tachycardia, myocarditis. CNS, it will lead to tremors, paresthesia, convulsion, finally leading to coma. And very important, metabolically, it will lead to metabolic acidosis, electrolyte imbalances, hypoglycemia, and liver and kidney failure. Hematological leukopenia is seen. So in the investigations, the ABC analysis will show acidosis, blood glucose will show hypoglycemia, LFT, KFT have deranged, CTC for leukocytopenia. Treatment is started immediately just by taking the history from the relatives. So management is very important. There is no specific antidote for sulfose poisoning. Management is purely supportive and symptomatic. So supportive care is maintain ABC. Then gastric lavage should be performed. It can be performed with vegetable oil also because it reduces the release of phosphine gas. Though activated charcoal is considered to be better, and it is given by nasogastrictive or orally to the patient. Then correct the electrolytes and acidosis by giving sodium bicarbonate to treat the metabolic acidosis. Specific interventions of magnesium sulfate. Magnesium sulfate is used to counter the toxic effects of aluminum phosphide, given intravenously, followed by maintenance doses every 4 to 6 hours. Then glucose should be given to counter hypoglycemia, benzodiazepines, manage the seizures, and a ventilator support for respiratory failure. Next is the methanol poisoning. So methanol poisoning, what are the sources of methanol? The sources of methanol are the antifreeze agents. It mostly consists of polyethylene glycol, however, industrial solvents, and sometimes it is adulterated with alcohol or illicit alcohol. Then the mechanism of toxicity is that methanol itself is not toxic, but its metabolic products like because of aldehyde dehydrogenase that will lead to formaldehyde and formic acid, it is going to be very much toxic in nature. So formic acid will responsible for morbidity and mortality. It leads to metabolic acidosis, optic nerve damage leading to blindness, and the central nervous system, it will lead to CNS depression. Clinical features. So early symptoms will be vomiting, drowsiness, ataxia due to loss of balance due to cerebellum effect. Apart from that, dysarthria will be seen. Late symptoms will be metabolic acidosis, tachypnea, seizures, and coma. Now, characteristic features are it is going to affect the optic nerve that will lead to blindness, optic disc edema is seen, and CNS effects will be headache, vertigo, delirium, and altered consciousness. It can also lead to pancreatitis. Investigation in the blood test, ABG is done, which shows the acidosis. Then electrolytes and osmolality, it will show high ion gap metabolic acidosis because the anions like the formic acid are increased. Then definitive test is going to be measuring the methanol concentration in the blood. Management, general support, that is airway, breathing, circulation is given. Apart from that, seizure control is done with the help of diazepam. Antidote that is given is used to block the dehydrogenase. So the antidote of choice is fomepizole, but it's orphan drug that is not easily available, so we go for ethanol. Ethanol is a competitive substrate to stop the metabolism of ethanol. Then correct for correction of acidosis, we use sodium bicarbonate infusion, and folinic acid is given. Why is folinic acid given? It enhances the metabolism of formic acid, and because of which the formic acid will be further degraded. Hemodialysis can done in case of severe cases, refractory cases, where there is a visual loss, renal failure, or persistent acidosis. Next is the barbiturate poisoning. So barbiturate poisoning, it causes serious depression by overdose of the barbiturate drugs, leading to respiratory depression and coma. The examples of phenobarbital, tendobarbital, and thiopental. Clinical features that relate to CNS system, that is drowsiness, confusion, coma. Respiratory system, there is respiratory depression. In cardiovascular system, it is hypertension, bradycardia, as well as hypothermia is seen, and amniosis, that is constricted vehicles. See, investigation, blood barbiturates level, and ABG for metabolic acidosis. What is the management? Initially, ABC should be done. Airway frequency should be maintained with the GC score of 2 is less than 8. Oxygen 4 to 6 liters per minute, and mechanical ventilation if ARD is like beaches. And circulation by IV access and continuous monitoring of the BP as well as pulse. Then gastric decontamination, so it can be done with the help of activated charcoal. Activated charcoal is given 1 gram orally or by the nasogastric tube, and the typical adult dose is going to be 50 to 100 gram. Multiple dose can be given, especially for the phenobarbital poisoning, that is 25 to 50 grams should be given every 4 hours. This enhances the gastrointestinal dialysis. Then there's something called as forced alkaline diuresis. So forced alkaline diuresis is used mainly for the phenobarbital poisoning, which is a weak acid. The drugs that is used for this is with the soda bicarbonate, and the dose is 1 to 2 milliequivalents per kg IV bolus. Then maintain the urine pH of more than 7.5. Then fluid therapy. For fluid therapy, for hypotension will be 0.9% normal saline, 500 to 1 liter bolus. Vasopressors like dopamine can be given. Then hypothermia, for that passive rewarming is done. Hypoglycemic dextrose is given, and enhanced elimination of barbiturates that can be done with the help of hemodialysis. Indications for hemodialysis are severe poisoning, if there is a very high serum for phenobarbital levels, renal failure, or persistent coma. Monitoring of the vital signs, ABG, renal function, and barbiturate levels is of utmost importance. Then apart from that, another thing is fluorosis. So fluorosis is a chronic condition that is caused because of excessive intake of fluoride. If and it damages the teeth and the bones. The excess fluoride intake means the intake is more than 1.5 milligrams per liter in the drinking water. Usually it should be less than 0.9. That is from the groundwater. In case of endemic areas, it is. The types of fluorosis, either it is dental and skeletal. So dental fluorosis, where there is a mottling of teeth, yellowish discoloration, and pitting of the enamel. Skeletal fluorosis, there is a bone pain, joint stiffness, restricted movements, osteosclerosis, and spinal deformities in severe cases. So that is spinal deformity is like kyphosis, as scoliosis can be seen. The investigation was to estimate the fluoride levels in the drinking water, and X-ray shows osteosclerosis. Urinary fluoride levels are taken. Management: removal of the fluoride source, use safe drinking water, nutritional therapy, calcium-rich diet, vitamin C and vitamin D, and symptomatic management. Analgesics are given for pain. For prevention, defluoridation of water is done. Use of safe alternative water sources and public health education is required. Then the next is the OP poisoning. OP poisoning, it's caused because of the irreversible inhibition of the acetylcholinesterase inhibitor. Then it leads to dumbbell-like features, that is diarrhea, urination, then meiosis, that is pinpoint pupil is seen, then emesis, lacrimation, salivation, right, increase secretions, then unconsciousness and muscle fasciculations is seen. We calculate the GCS score, that is given by eye response, verbal response, and the motor response, and the score is 4, 5, 6. So elaborate this score. Apart from that, in the management, first we go for the ABC, and then GCS. Then we give the gastric levels with the help of activated charcoal. 1 gram per kg, ideally in adults 50 grams is given. Then place the person on left lateral position, wash the skin because it passes through the skin. Then IV access is secured fluid oxygen is given. Then vital subject BP, arterial blood gas monitoring. Then CBC, kidney function test, liver function test, ECG, electrolytes, and arterial blood gas analysis is done. Then atropine 1.8 milligram IV is given. Check the vitals after 5 minutes. If the heart rate moves to more than 80 or SBP more than 98, clear chest is seen. Then these are some of the signs which are important. Double the dose if the signs of atropinization are not present. If signs of atropinization is seen, then atropine infusion 20% of whatever the dose is required for atropinization. This infusion, continuous infusion is given. Then pralidoxime 30 mg per kg is given over 30 minutes and give until the atropine is not needed, and it should be given at 8 to 12 mg per kg per hour. And diazepam 10 milligram IV is used to control the agitation in this person. A snake bite. Snake bites. So remember, not all snakes they are venomous in nature. Only 1/3 of the snakes are venomous, and major venomous snake families they include the vipers. Then in Lapidae that is includes the great cobras and the mambas. Then venom composition greatly varies within the same species across different geographical regions. For example, a Russell viper is a vasculotoxic snake. So in South India it leads to bleeding manifestations, while in case of Sri Lanka it leads to muscle damage. Right, myonecrosis is same. Then clinical features, it depends upon the snake species, then geographical region, and the venom composition. So these are all the features. Then the vipers. So vipers consist of the Russell viper and the sausage viper. The local signs of this, they are the pain, swelling that leads to tissue damage, as well as the necrosis. Systemic signs are obviously it leads to coagulopathy, that is bleeding manifestations, hematuria, acute kidney injury. Then hypertension because of the capillary leakage, and rhabdomyolysis, that is muscle breakdown. Now in Sri Lanka, this Russell viper can even lead to neurotoxicity, while in South India it leads to pituitary hemorrhage. Then crates is the Bangara species. So the common crate, their bites are often painless, but they lead to delayed flaccid paralysis, that is neurotoxicity seen. It is associated with severe abdominal pain and hyponatremia. Cobra species, that is called as naja, they cause neurotoxicity, notably ptosis or drooping of the eyelids is seen, and paralysis, and can cause local necrosis. Some cobras they can spit the venom and cause eye or skin damage. Management, the first line management is right, that is the reassure the patient, immobilize the limb, use the splint to support it. Then do not do suction, do not do any incision over the wound or apply a tourniquet, and go to the hospital, call for help, and transport to the hospital immediately. So hospital management, IV fluids are given for shock, dialysis should be done for acute kidney injury. If it is a case of viper snake, then blood transfusion is done, or fresh frozen plasma is given for coagulopathy. If it's a neurotoxic snake, then respiratory support, mechanical ventilation, neuroparalysis, especially with cobra bites or crate. Then polyvalent venom is used. Now this polyvalent venom is not useful against the hump-nosed viper, killback species, and Asian or African saw-scaled viper. Then this is given according to different dose and different vials, and supporting care by anti-tetanus vaccines, antibiotic, neostigmine, and glycoviral that is used instead of neostigmine. Now very important, in detailed approach to the management. So India mainly has this big four venomous snakes, that is Indian cobra, common great Russell viper, and saw-scaled viper. And so this polyvalent venom, it is effective against these four venomous snakes. So the management is reassure the patient, immobilize the limb, remove any tight clothing or jewelry, keep the limb below the heart level, and transport immediately to the hospital. Avoid tourniquet, suction, incision, or any ice or chemicals. In hospital management will be ABC obviously first. Then we have to do a baseline test, that is the 20-minute whole blood clotting test, CBC, PTINR, kidney function test, and urine examination. Indications for antivenom. Give polyvalent anti-snake venom if neurotoxic signs are present, that is ptosis, dysphagia, respiratory paralysis, hemotoxic signs like this bleeding, coagulopathy, and cardiovascular signs, that is hypotension or shock, and severe local evenemation is present, that is rapid swelling and pain over the site of bite. So the ASV dose that is given is initial dose of 5 vials is given. If it is mild, if it is moderate, 10 vials are given, and if it is severe, 10 to 20 vials are given. And this should be given in 200 to 500 ml of normal saline over 1 hour. Repeat the dose if there is a persistent bleeding, neuroparalysis, or abnormal WBCT. The management of ASV reaction, there's sometimes anti-snake venom can have reactions. If it is mild reaction, we get chlorpheniramine or hydrocortisone. Severe reaction, that is anaphylactic reaction, and 0.5 mg intramuscularly 1:1000 ml of adrenaline is given. The management of neurotoxic innovation, for that atropine is given 0.6 mg intravenously along with neostribin 1.5 milligram intravenously. This is used to prevent a respiratory paralysis. Also, ventilatory support is provided. But better than this is the glycopyrrolate because it does not cross the blood-brain barrier. In case of hemotoxic or vascular toxic snakes, we go for fresh frozen plasma administration and always monitor the 20-minute whole blood CD. Supportive management is IV fluids, analgesics. Obviously, you should give TT prophylaxis to this patient and antibiotics. Then the complications will be acute kidney injury, respiratory failure, DIC, and compartment syndrome if tied. And scorpion envenomation. So scorpion sting is caused because of the sting of the scorpion leading to autonomic storm due to massive release of the catecholamines. It is mainly because of the Indian red scorpion. And pathophysiology, there is excess release of catecholamines, autonomous nervous system overactivity is seen. This produces an autonomic storm that leads to hypertension, tachycardia, pulmonary edema, and myocardial dysfunction. In clinical features, at the local symptoms, there is a severe pain at testing site, burning sensation, and a local swelling is seen. Systemic manifestations, so autonomic signs are sweating, salivation, vomiting. Cardiovascular manifestations are tachypnea, tachycardia, hypertension, arrhythmia. Respiratory symptoms of pulmonary edema, breathlessness, and neurologically restlessness and agitation is seen. In investigation, we go for ECG, chest X-ray, blood glucose and serum electrolyte levels, as well as CBC. Then detailed management. So first, aid is reassured the patient, immobilize the affected part and transport to the hospital immediately. Local pain control is given by lignocaine. Lignocaine 2% is given 2 ml solution locally. Specific therapy drug of choice for scorpion sting is the prazosin. It is alpha 1 blocker, reverses the autonomic storm. It is given 30 microgram per kg orally. So the typical dose is about 1 milligram orally. And scorpion antivenom is given for severe systemic envenomation. 1 to 2 vials IV are given. Then management of pulmonary edema, for that oxygen therapy is given, diuretics, that is furosemide is given 20 to 40 milligram IV. Cardiac support is by dobutamine, and the supportive care is IV fluids, but they should be given carefully. If there is acute pulmonary edema, you should not give it. Continuous ECG monitoring, mechanical ventilation if respiratory failure. Complications are acute pulmonary edema, cardiogenic shock, arrhythmias, and death. Then the first is the heat exhaustion. So heat exhaustion, where the core body temperature is usually elevated, but still it is less than 41 degrees Celsius or 40.5 degrees Celsius. The two physiologic precipitants, they are going to be the water depletion that happens and the sodium depletion, that is hyponatremia, which occur in combination. So heat exhaustion is seen in laborers, athletes, elderly individuals who are involved in exertion in hot environments without adequate fluid intake, electrolyte balance, and they tend to develop the water depletion, heat exhaustion. Persons working in the heat frequently consume 2/3 of their net water loss and are voluntarily dehydrating. In contrast, salt depletion, heat exhaustion, it occurs mostly in unacclimated persons who have been consuming large amount of hypotonic solutions. So that will lead to salt depletion, heat exhaustion. So water depletion, heat exhaustion is one, and this is the salt depletion, heat exhaustion. Clinical causes are headache, vertigo, then there will be ataxia, impaired judgment, nausea, muscle cramps, moist and clammy skin will be present, dilated pupils. Now it's a salt depletion, then that will be hyponatremia, hypochloremia, hepatic aminotransferase levels are increased, and low urinary sodium and chlorine is seen. Management, aggressive cooling should be done until the core temperature of the body reaches to 39 degrees Celsius. Then IV isotonic normal saline, that is 0.9% normal saline is given. It is given over 24 to 48 hours. Maintenance of the electrolytes is important, and monitoring and reassurance are important. So remember, in heat exhaustion there are two types: water depletion, heat exhaustion, and sodium depletion or salt depletion, heat exhaustion. Water depletion is seen in those who do exertion in hot environments, and salt depletion is seen in those who occur in unacclimated persons. The important thing, that is heat stroke. So heat stroke is of two types, that is classical heat stroke, or that is also called as non-exertional and exertional heat stroke. So classical non-exertional heat stroke, it is because of the summer heat waves, which is insidious or gradual in onset. It is more common in elderly individuals, debilitated patients, that is any amputated persons with chronic diseases, or rhabdomyolysis and acute renal failure patients. Then the exertional heat stroke. Exertional heat stroke is seen in young healthy individuals. It's generally seen in people, in laborers, in athletes who do exertion in hot temperatures. they have a predisposing factor, and this is more common. That is, exertional type of heat stroke is more common as compared to heat stroke in non-exertional type. Then predisposing factors. So predisposing factors are the increased heat production, that is seen in case of hyperthyroidism, exercise, or sepsis. Then impaired heat loss, that is impaired sweating. The drugs that impair the heat are the anticholinergics, anti-Parkinson drugs, antihistaminics like phenothiazine or tricyclic antidepressants, abnormal sweat glands, salt and water depletion because of diuretics or hypokalemia. So these are all the reasons for impaired heat loss due to impaired sweating. Then impaired voluntary mechanism, there is coma, then psychosis or physical disability, impaired blood flow to the peripheries, that is seen in cardiovascular disease, peripheral arterial disease, hypokalemia, dehydration, and elderly patients, humidity, then poor ventilation, lack of acclimatization, obesity. So these are another predisposing factors or risk factors for stroke. Clinical features, there are three cardinal signs that are seen. CNS dysfunctions of patient can be disoriented to timeless in person, can be GC score will drop. Then there is hyperpyrexia, that is the core body temperature increases to more than 41 degrees Celsius, and there is a hot dry skin and loss of thermoregulation from the body. Constricted vehicles or miotic vehicles are seen. The CNS manifestations, there will be first irritability, irritation, and followed by a complete confusion, aggression, delirium, convulsions, and finally the person can go into coma. Cerebellar signs are ataxia and dysarthria can be seen. Then CVS, there is first tachycardia, dysarrhythmias, then the patient will go hypotensive and myocardial pump failure due to muscle damage. In the respiratory system, extreme tachypnea up to 60 per minute, and followed by silent chest. Then metabolic, in the metabolic there is hyponatremia, hypomagnesemia, hypokalemia during the early phase. Hypokalemia decreases the sweat secretion, and because of which the heat loss is prevented. Rhabdomyolysis, it results in hyperkalemia, hypocalcemia, and the renal failure. Then metabolic acidosis and respiratory alkalosis, they are common. So in case of heat stroke, they relate to metabolic acidosis and respiratory alkalosis because of tachypnea. Then DIC, bleeding chances increase. Then investigations. So investigations, you have to maintain record the temperature. Then CBC, electrolytes, liver function test. Then for rhabdomyolysis, you go for creatine kinase levels, ABG analysis, ECG monitoring, urine output monitoring. Then for DIC, we look for the full coagulation profile of the patient and test the urine for myoglobin. Now management, the first aid. First aid is always move the person to a cooler location, loosen or remove the clothing, then cool the victim with water with a fan, wrap in the wet sheets, then cold compress is given at the head, neck, armpits, and groin region. Urgent medical attention is required. No antibiotics should be given. Then hospital. In the hospital, supportive IV fluid is given. Treat the hyperkalemia, because hyperkalemia, initially there is hypokalemia. Hyperkalemia sets in because of rhabdomyolysis. So for that, calcium gluconate is given. Calcium gluconate also helps in hypocalcemia, that is also seen. Then ECG changes of severe hypokalemia occur, or hypocalcemia, because of increased rhabdomyolysis. Then mannitol can be given, an IV lorazepam for shivering. Then avoid any antibiotic agents like paracetamol. Various cooling methods that can be carried out in heat stroke are immersion into the ice packs, immersion into the water, the strategic ice packs. Ice packs are kept on the head, neck, in the armpits, and in the groin region. Ice packing, cooling blankets, gastric lavage, cardiac bypass, and cooling catheters can be used. And hyperthermia. Hyperthermia is a dangerous rise in the body temperature due to the failure of thermoregulatory mechanisms, where the heat production exceeds the heat loss. So the hyperthermia, the causes for hyperthermia are the heat stroke. Then apart from that, excess environmental heat temperature. If there are certain drugs consumed that will impair the heat loss, that is anticholinergics, sympathomimetics, anti-Parkinson drugs, tricyclic antidepressants, or malignant hyperthermia due to any anesthetic intake. The clinical features here: the body temperature is high, more than 40 degrees Celsius, hot dry skin, tachycardia is seen, tachypnea up to 60 per minute, and headache, altered consciousness, and seizures. Over here, there is going to be metabolic acidosis and respiratory alkalosis. Similarly, it is characterized by hyperkalemia and hypocalcemia. In the management, immediate cooling measures, cold sponging, ice packs should be applied at strategic locations. Then the IV of fluid is for dehydration, oxygen therapy, anticonvulsant purposes. Complications are multiple organ failure, shock, and death. And hypothermia. Hypothermia is a fall in the core body temperature below 35 degrees Celsius due to prolonged exposure to the cold environment. So the causes are exposure to cold environment, immersion in any cold water, alcohol intoxication in the individual, and endocrine disorders like hypothyroidism. Clinical features are shivering, cold, pale skin, bradycardia, slurred speech, confusion, loss of consciousness in severe cases. Management for that gradually rewarming should be done, that is warm blankets, warm IV fluids should be given. Then there is oxygen therapy, monitor the vital signs, treat underlying cause, complications of cardiac arrhythmias, respiratory depression, and cardiac arrest. So the starting with vitamin B1 deficiency. So vitamin B1 is called as thiamine, which is a water-soluble vitamin of the B complex, and plays a crucial role in the as a coenzyme in energy metabolism, and particularly for the nervous system as well as heart. The active form is called as the TPP, that is thiamine pyrophosphate. It is absorbed in the small intestine and converting to this form. It is involved in carbohydrate metabolism. Then pyruvate dehydrogenase. So pyruvate dehydrogenase converts the pyruvate into the acetyl coenzyme. It is also present in alpha ketoglutarate dehydrogenase, which is an important enzyme Krebs cycle. And transketolase. Transketolase is a key enzyme in the pentose phosphate pathway, and this enzyme is a marker of the red blood cell activity. Then the next is the branch cell amino acid dehydrogenase. So it is found in pyruvate dehydrogenase, then branch chain amino acid dehydrogenase, alpha ketoglutarate dehydrogenase, and trans ketolase. Then the dietary sources. The dietary sources are whole grains, legumes, that is peas, beans, lentils, nuts, pork, and yeast. Very important, the Polish rice. It leads to vitamin B1 deficiency. So causes of B1 deficiency are the polished rice in parts of Asia, and diet which is highly processed. Then chronic alcoholism is the most common cause in the Western world. Alcohol impairs the thiamine absorption, and because of which the DPP won't be formed. The malabsorption in cases like the celiac disease, Crohn's disease can lead to it. Increased demand in case of pregnancy, lactation, fever, hyperthyroidism, and chronic illnesses like HIV, AIDS, cancer, or long-term dialysis can be the cause for vitamin B1 deficiency. Now talking about the deficiency syndromes and its clinical features, so it can lead to dry beriberi, which is a neurological form. This is a peripheral neuropathy, and this results from the damage to the myelin sheath of the nerves. Then symptoms. The symptoms that are seen are the peripheral neuropathy, which is characterized by numbness, tingling sensation, and burning sensation in the feet and the hands. The signs that are seen are muscle weakness, then wasting can be seen in the distal part of the limbs, calf tenderness, loss of the deep tendon reflexes, and the patient feels difficulty in walking. Then wet beriberi is the cardiovascular form. Here there is results from the high output cardiac failure due to vasodilation. So here there is a shortness of breath on exertion, palpitations, fatigue. Then the signs are tachycardia, then a wide pulse pressure is seen, warm extremities they are seen due to peripheral vasodilation, edema is seen, and eventually it can lead to pulmonary edema and heart failure. Now this is often called as Shoshin beriberi when it presents acutely or fulminantly. Then another syndromes are the Wernicke-Korsakoff syndrome, that is acute syndrome. This is seen in case of chronic alcoholics. So here Wernicke's encephalopathy, which is acute medical emergency, is characterized by this triad, that is GOA, that is global confusion. Then O stands for ophthalmoplegia due to the weakness of the paralysis of the eye muscles. Mostly there is a sixth nerve palsy, that is lateral rectus muscle palsy, and ataxia, which is a wide-based and unsteady gait. Korsakoff psychosis, it is seen in chronic conditions. It often follows the Wernicke's encephalopathy. It is characterized by anterograde amnesia, that is inability to form new memories, retrograde amnesia, that is loss of past memories, and confabulation, that is storytelling. And Korsakoff psychosis in an infantile beriberi. So infantile beriberi, it occurs in breastfed infants of the thiamine deficient mothers. It is found around 2 to 4 months of age. It can present as cardiac, that is acute fulminant cardiac failure, or aphonic, that is loss of voice form. So diagnosis is often clinical and based on the history and symptoms. So lab test measurement of erythrocyte transketolase activity, which is the marker of thiamine deficiency, and a TPP effect, and increased enzyme activity after giving TPP in vitro is a sensitive indicator for deficiency. Then blood and urine thiamine levels can also be measured, but they are less reliable as compared to transketolase activity. Management: high dose thiamine supplementation is given. So it might be given for suspected Wernicke's encephalopathy. The thiamine must be given intravenously or intramuscularly immediately, that is 100 to 200 milligrams is given before glucose or carbohydrates. because if glucose and carbohydrates are administered first, that will rapidly deplete whatever the thiamine stores are present and will worsen the neurological damage. For other forms of beriberi, oral thiamine can be given 10 to 20 mg per daily. So basically in vertigus encephalopathy, IV 200 milligrams is given, and in normal vitamin B1 deficiency, oral thiamine 10 to 20 mg daily is given. Supportive care, so treatment of heart failure drugs, nutritional support, and alcohol dependence should be managed. Prevention can be dietary diversification, food fortification, thiamine supplementation of at-risk populations. At-risk population, that is those who are on dialysis, cancer, or chronic alcoholics. Then talking about the vitamin B3, that is niacin deficiency. So vitamin B3, also called as niacin, again it's a water soluble vitamin. It consists of two components, that is nicotinic acid and nicotinamide. It is a precursor for crucial enzymes, that is NAD plus and NADP plus. Then the biochemical functions is NAD and NADP are essential coenzymes for a lot of enzymes. So these are crucial in the cellular energy metabolism. They act as the electron carriers in the redox reactions like glycolysis, Krebs cycle, as well as ATP production, oxidative phosphorylation. Then fatty acid and steroid synthesis as well, it is very important. For that, NADPH is a key reducing agent. Then for DNA repair and maintenance, NAD plus is a substrate. And for cell signaling, NAD plus is used to produce signaling molecules like calcium mobilizing agents. Dietary sources of vitamin B3 are the animal sources, that is the meat. So especially the liver of the organism, poultry, fish, tuna, salmon. Then the plant sources. The plant sources are the legumes, nuts, whole grains, and enriched minerals. Endogenous synthesis. Endogenous synthesis, the body can synthesize a small amount of niacin from the essential amino acid, that is TRV, that is tryptophan. So 60 mg of tryptophan will lead to 1 milligrams of niacin. The causes of deficiency. The deficiency of vitamin B3 is called as the pellagra. Pellagra means the rough skin. It is a classical deficiency, classic disease of the niacin deficiency. It is associated with dietary deficiency. So the diets which are based on non-fortified maize, because maize can lead to tryptophan deficiency. Then the alcoholism, then malabsorption syndromes like the Crohn's disease or chronic diarrhea. Then drugs like the isoniazid, which is used for tuberculosis, can also lead to vitamin B3 deficiency, which interferes with vitamin B6, a cofactor for tryptophan metabolism. Hartnupp's disease is a rare genetic disorder causing defective tryptophan absorption in kidneys. Then carcinoid syndrome is where the tryptophan is diverted to produce serotonin instead of niacin. And talking about the clinical features, so there are 4 Ds of pellagra. So the 4 Ds are, first is the dermatitis. So there is a photosensitive rash that appears on the exposed skin. That looks like a necklace, that is called as the Castle's necklace. It is present on the back of the hands and the feet as well. The lesions are erythematous, that is red, are rough and scaly. In chronic cases, the skin becomes hyperkeratotic and pigmented. In then diarrhea, it involves the GI tract that leads to nausea, vomiting, abdominal pain, and inflammation of the mucous membranes of the mouth leading to stomatitis. Then there is dementia. Neurological and psychiatric manifestations can be seen. It is confusion, hallucination, psychosis, depression, anxiety, and death if left untreated. Then diagnosis, it's primarily clinical based on the characteristic symptoms and dietary history. Measurement of urinary metabolites like N-methyl nicotinamide can be used, or low serum niacin or tryptophan levels can be seen. In management, so treatment, it is high dose niacin or nicotinamide supplementation is given. So here 50 to 100 milligrams of niacin is given orally 3 to 4 times a day. So total dose of 300 to 500 milligrams is rapidly effective. Nicotinamide is generally preferred for treating pellagra because it does not cause the unpleasant flushing and vasodilation that is associated with nicotinic acid. So nicotinamide is preferred over nicotinic acid, so that the flushing doesn't happen. And the skin and the GI symptoms usually improve within a few days, while the neurological symptoms recovery may take weeks or months. Dietary improvement, a well balanced diet rich in protein, meat and vegetables should be consumed. Then prevention can be food fortification and public health measures to promote the food diversity should be taken. Now the next is vitamin B7, that is biotin deficiency. So vitamin B7, also known as biotin, again it's a water soluble vitamin, and it is very important. Acts as a coenzyme for all the carboxylase enzymes. So the biotin is a cofactor for 5 key carboxylase enzymes. So to remember, acetyl coenzyme carboxylase involved in fatty acid synthesis, pyruvate carboxylase involved in gluconeogenesis, then propionyl CoA carboxylase, it is involved in metabolism of amino acids, and methyl protoyl CoA carboxylase involved in the breakdown of leucine. Then the dietary sources. Biotin is widely available in food, making the deficiency rare, but however the good sources they include the egg yolk. So the yellowish portion, that is the egg yolk, is important, while the egg white, it contains avidin, which prevents the absorption. Then liver and other organ meats can be consumed. Then nuts, that is almonds, peanuts, consist of vitamin B7, whole grains, legumes, and mushrooms. Then the cause of deficiency. So the causes of deficiency is uncommon, but it can occur due to excess consumption of the egg whites. So egg whites is generally consumed by the gym freaks because the egg yolk contains higher levels of cholesterol. So they consume only the raw egg whites, and this avidin then will lead to decreased absorption of the biotin. Then malabsorption syndromes like Crohn's disease or short bowel syndrome. Then long-term parenteral nutrition medications like anticonvulsants, phenytoin. Then pregnancy where there is increased demand, lactation, and inherited disorders, that is multiple carboxylase deficiency, and also lead to this. The clinical features will be dermatological. Here there will be dry scaly dermatitis, often around the eyes, nose, mouth, and hair. The thinning of the hairs happen, which may then progress to total alopecia. Then in neurological, there can be mild depression, lethargy, fatigue, hallucinations, and paresthesis. And systemic, there is a loss of appetite, nausea, and metabolic acidosis can happen. Diagnosis and management is based on clinical presentation and history of risk factors. Laboratory diagnosis can be made by measuring the urinary secretion of biotin or organic acids like isovaleric acid. Then biotin supplements can be taken orally. Dose of 5 to 10 milligram daily is used to relieve the symptoms, and prevention of the only raw egg white should be done. The next is central obesity and the indications for bariatric surgery. So central obesity, also called as the visceral obesity. So here it is due to the excessive accumulation of the fats in the abdominal region, especially around the viscera, that is internal organs and the subcutaneous tissue of abdomen. It is clinically significant because this type of fat distribution is more strongly associated with metabolic and cardiovascular complications. Then the assessment, it is done by measuring the waist circumference and waist to hip ratio. So the waist circumference measured at the midpoint between the lower rib and the iliac crest. So if it is more than 90 centimeter in case of men and more than 80 centimeter in case of females for Asian population, and for Western population more than 102 centimeter and more than 88 centimeter in case of females. The waist to hip ratio, if it is more than 1 in case of men and more than 1.85 in case of females, that is considered to be obesity. Why does it occur? Because of the increased free fatty acids. The visceral fat is metabolically active and releases large amount of free fatty acids into the portal circulation. This directly contributes to insulin resistance, and because of which further there can be a risk of type 2 diabetes mellitus. Similarly, dyslipidemia because of the increased production of VLDL and triglycerides and decrease HDL levels. Then dysregulated adipokine secretion. Adipose tissue, it secretes the hormones like adipokine. In central obesity, there is decreased secretion, and protective hormone like adiponectin is produced, and because of which it protects against the burning of this central fat, further worsening insulin resistance. Then what are the indications for bariatric surgery? So NIH, it gives the indication for bariatric surgery as if there is a BMI of more than or equal to 40 kg per meter square, that is morbid obesity or severe obesity is present, or BMI more than or equal to 35 with any one comorbidity is present, for example diabetes or insulin resistance, like. Then the presence of serious obesity related complications in BMI 35 to 40, for example type 2 diabetes, metabolic syndrome, cardiovascular complications like hypertension, dyslipidemia, or mechanical like severe OSA, that is obstructive sleep apnea, or obesity hypoventilation syndrome. Obesity hypoventilation syndrome, that is called as the Pickwickian syndrome. And other syndromes that include the non-alcoholic steatohepatitis and debilitating osteoarthritis. If there is a failed conservative management, that is the patient must have a documented history of failed attempts at significant weight loss even after doing a lot of exercise, supervised diet and behavioral modification programs. And if there is a patient preparedness, obviously the patient should be psychologically stable and motivated. They must understand the procedure, necessary lifelong lifestyle changes, and the potential risk and complications. There should be an acceptable surgical risk as well. Also, there can happen multiple nutritional deficiencies because of the bariatric surgery operations. Contraindications, it is Contraindicative with this psychiatric illness, active substance abuse is present, lack of understanding and inability to comply with the lifelong medical and nutritional follow-up. So starting off with the first, that is zinc deficiency. So zinc deficiency again is an essential trace element that is critical for over 300 enzymes. So it acts as enzyme cofactors for carbonic anhydrase, alkaline phosphatase. Then it is involved in the protein synthesis, cell growth, immune function. It acts as an antioxidant and helps in neurotransmission. Causes of zinc deficiency are inadequate intake. It is seen in population where the dietary consumption of phytates is high. Then Similarly, in malabsorption conditions like celiac disease, Crohn's disease, or short bowel syndrome, there increased losses as in case of chronic diarrhea. There increased requirements in case of infancy, puberty, and lactation, and chronic liver disease and alcoholism. The clinical features. The specific clinical feature over here is the acrodermatitis enteropathica. That is seen in severe deficiency. It's a characteristic rash that is perioral in nature. It involves extremes, that is acral and perineum. It is pustular or eczematous in nature. In the gastrointestinal, it will lead to diarrhea, growth retardation, stunting in children, then delayed wound healing, immune dysfunction is seen, then alopecia, hair loss, and neurologically it will lead to irritability, neurophysiological performance, hypogeusia, that is impaired taste or metallic taste, and hyposmia, that is impaired smell, can be seen. Diagnosis and management is based on clinical suspicion, dietary history, and measurement of serum zinc levels. The management is oral zinc supplementation, 1 to 3 milligram per kg per day should be given. For severe deficiency, intravenous zinc is given. Dietary modification can be zinc-rich foods like red meat, poultry, seafood, and address the underlying cause. And talking about a vitamin E deficiency, vitamin E is a fat-soluble vitamin and it exists in multiple forms, but tocopherol and tocotrienols is important. So alpha tocopherol is going to be the biologically most active form. Then biochemical function is that it acts as an antioxidant. It neutralizes the free radicals by lipid peroxidation. It inserts itself into phospholipid bilayer of the cell membranes and prevents oxidation of polyunsaturated fatty acids. Then interaction works in concert with other antioxidants such as glutathione and selenium. Causes of deficiency are, it is widely available in foods and stores in adipose tissue, but the deficiency is rare. It is seen only in case of fat malabsorption syndromes. Then the next is fat malabsorption. So fat malabsorption, it can be seen in case of cystic fibrosis, then cholestatic disease, short bowel syndrome, celiac, or the Crohn's disease. A beta lipoproteinemia is also a condition where vitamin A deficiency can be seen. And the clinical features will be peripheral neuropathy, cerebellar ataxia, ophthalmoplegia, retinopathy, hemolytic anemia in premature infants leading to hemolytic disease of the newborn, and myopathy can be seen, that is skeletal muscle weakness. Diagnosis is based on the risk factors and the low levels of alpha tocopherol in the plasma it sees. Then management is high dose vitamin E supplementation, thousands of units of international units per day is given, and water soluble forms of vitamin E is available for severe malabsorption. UNICEF measures to combat the malnutrition is the United Nations International Children's Emergency Fund. It is a global organization to end the children malnutrition. So it is a conceptual framework that addresses the immediate underlying and basic causes of malnutrition. So UNICEF conceptual framework is immediate causes, that is inadequate dietary intake and disease, underlying causes, that is household food security, inadequate care for children and women, and the basic causes like socio-economic and political factors like poverty should be seen. What are the key strategies? The key strategies are IYCF, that is infant and young child feeding practices. So there should be promotion of early breastfeeding and exclusive breastfeeding for the first 6 months of life. Then promotion of appropriate complementary feeding that are having all the nutrients. Then micronutrient supplementation, that is vitamin E supplementation, it should be started by 6 months of age to reduce the child mortality and prevent the blindness. It should be given from 6 months to 5 years of age. Then multiple micronutrient powders, they should be given from 6 months to 23 months to prevent anemia and micronutrient deficiencies. Then food fortification to add essential vitamins and minerals to the staple food, for example iron and folic acid, then salt with iodine and oil with vitamin A. Then management of SAM, severe acute malnutrition, here it is to form a ready-to-use therapeutic foods wherein 500 kilocalories is present and it contains somewhere about 10 grams of protein. It consists of high energy nutrient dense pastes. This allows the children to be treated at home rather than at hospitals. Then maternal nutrition. So maternal nutrition is to provide iron folic acid supplementation to the pregnant woman to prevent anemia and neural tube defects. Also nutrition and rest for adults and girls, mothers and pregnant and lactating women. Then disease prevention and management. So promote hand washing, safe water drinking and sanitation. Similarly, ORS promotion should be done. Advocacy, policy and data, that is supporting the national nutritional surveys. Anthropometric measurement should be taken. Sustainable development goals should be fulfilled, and emergency response in the form of ready-to-use therapeutic foods and micronutrient supplements in humanitarian crises like conflicts, wars, natural disasters, famines. And then hypervitaminosis A. Hypervitaminosis A, it refers to the toxic effects of fat soluble vitamin, that is vitamin A. It is not readily excreted in the urine, accumulates in the liver and the adipose tissue into the ITO cells of the liver, and the toxicity happens. So toxicity it almost never happens because of the consumption of vitamin A rich foods like carrots or livers, but it is seen in extreme cases like consuming polar bear liver. Excessive supplementation is the most common cause. Taking high dose vitamin A tablets for prolonged periods can cause toxicity or megavitamin therapy. Then overuse of medications containing retinoids for acne, and accidental ingestion can be seen in case of children. Then the types are acute hypervitaminosis A. This is because of a single very high dose, that is thousands of international units of consuming polar bear liver. Then the symptoms they develop within hours to few days. The features are severe headache, nausea, vomiting, dizziness, drowsiness, and blurred vision or diplopia can be seen, and a bulging fontanelle in infant is a classical sign. Chronic manifestations when moderately high doses, that is 25 to 50,000 international units, are taken for a long period of time. Here it will lead to dermatological manifestations like a dry, rough, itchy skin, then peeling of the lips, that is cheilitis, alopecia, hair loss, and brittle nails can be seen. Then hepatological manifestations, that is hepatomegaly, because obviously the storage happens in the liver. Then apart from that, liver damage can happen. Neurological manifestations like persistent headache, visual disturbances, and musculoskeletal manifestations like myopathy can happen, and hyperostosis, that is excessive bone growth. Premature closure of the epiphys in children can be seen. Then diagnosis, detailed history of the dietary habits or any accidental intake can be seen. Physical characteristics like skin changes, hepatomegaly, and laboratory tests will show increased levels of serum retinol. Then management. So management is discontinuation and stop all the vitamin E supplements. Supportive care is given, cessation of the vitamin like, and treat the complications like liver damage or persistent intracranial hypertension. Otherwise, there is no specific antidote for this. So this is all about the nutrition as well.